Right, so good evening, everybody. So today we're going to talk about neuro-intensive management of severe traumatic brain injury. I know Sharice had done quite two comprehensive talks on pretty much all the aspects of neuro-intensive. I'll just put it in a short presentation here. I'll just put it in context to management of our severe traumatic brain injury and spend most of the time talking about protocols for such cases, right? Um, so, so essentially, when you think about how do you manage a patient with increased ICP in a head injury patient, you follow your usual ATLS protocols, and then you have physiological aspects that you could manage, and then you have pharmacological agents that you could use that would help in bringing down the secondary injuries, and then lastly, you have your surgical adjuvants that you could use along the way and managing these patients. So let's see if we can get all these together into our formula and use them in our step and our tip, right? So, so the essentially why we need the protocols or why we need to have a standardization of treatment. That's a big question, and it has been answered since 1990s. Like in 1997, they had a European Brain Injury Consortium 1997 guidelines based on the consensus and expert opinion, which which probably released one of the first international guidelines to follow for head trauma patients. And then in 2016, you have Brain Trauma Foundation that came up with guidelines. And recently, they had the Seattle International Severe Traumatic Brain Injury Consensus Conference, which came about with new algorithms and new to manage brain injuries. Now, as we know, the brain injuries have primary injury and the secondary injury, and we have no control over the primary injury. And there's very little that we could do when it comes to primary brain injury, but we have a little bit of control to an extent to reverse engineer the whole physiological and pathological process in the brain and try to return to normalcy as much as possible. But taking that into consideration, we should also understand that we can't standardize our treatment plan and accept that and expect everybody to follow the rigid standardization plan. So if you look at across the world, most of the institutions have their own treatment protocols that they follow, right? All of these are derived from the core principles that are recommended from these conferences or the guidelines or the foundations I had spoken about earlier. So the ultimately the trend in reduced mortality and improved outcomes from traumatic brain injury has been a result of this evidence-based protocols, and it emphasizes on optimization of the physiological parameters, which in return minimizes the secondary brain injury. So let's look at our general ICU care. We have a patient that comes into casualty, we follow the ATS protocol, and we did secondary survey, and we diagnose them with severe traumatic brain injury. So first thing that we're going to do is we bring them to ICU, and it starts with positioning. And the entire positioning, the core principle of positioning revolves around decreasing the venous congestion and increasing the blood back from the brain to the heart and extremities back to the heart and back to the extremities. So in order to do that, we usually tend to have our patients in a 30-degree head up. Unless there's a contraindication, the spine is not clear, then you tilt the entire table to 30 degrees head up, but also create a flexion at the hips to facilitate return of blood back to the lower extremities to the torso. And you also try and maintain the head and neck in a neutral alignment without any neck flexion. And then if you had to turn the patient, you use the maximum amount of hands that you could get, or at least minimum of 3 staff members, to maintain the head and neck neutral alignment and positioning, right? And then you have to ensure that there's no jugular vein compression, which could increase the mean ICP and throw off the amplitude on P1 3 waves. We'll get to that a little later. And if the patient is unconscious, you have to make sure that you clear the cervical spine using your ATLS or your institutional protocols. The next thing is going to go into is venous thromboembolic embolic prophylaxis. Now, you have to immediately commence the compression stockings and intermittent pneumatic compression stockings as a mechanical prophylaxis for all traumatic patients, unless there's absolute contraindication. Whereas if you look at chemical thromboprophylaxis, the patients with low risk of bleeding, you could start them at 24 hours based on what the CT scan shows. And then for those at moderate, you could consider at 72 hours, once again, based on what the CT scan. For those at high risk of bleeding, use caution in starting the chemical thromboprophylaxis. And um, and you commence them after or within the 72 hours. But you have to pay great attention to the risks and outweigh the pros versus cons before you start it. And if you look at IVC filters, some authors just recommend you could put in an IVC filter, but there's no associated reduced risk of symptomatic PE or death from placing an IVC filter. Now, low molecular weight heparin may be superior to unfractionated heparin, and use should be guided by anti-10A assays. And unfractionated heparin should be used as an alternative where indicated by institutional guidelines again. Now, for the nutrition aspect, head injury patients or severe head injury patients are in a hypermetabolic and catabolic state. So enteral feedings within 24 hours of admission is usually recommended. That would prevent any nutritional abnormalities, or it will meet the requirements that the body needs and also help in preventing Cushing ulcers to an extent. If you have a suspicion of chronic alcohol abuse or malnutrition, you could consider an elemental feeds followed by early enteral vitamin conversion to enteral vitamin feeds. But generally speaking, all patients should attain a full caloric replacement by day 7 post-injury. And you should also monitor patients that have been started on delayed feeds to look at, just have to look out for refeeding syndrome. And for the blood glucose levels, the target is to maintain them at a normal glycemic index. So you monitor your blood glucose levels every 2 to 4 hours from admission, and once the glucose is stable at 4.5 to 10 millimoles per liter, then you could decrease the frequency to once a day. And if there's a need for it, if there's an indication, you could commence your variable rate infusions, and it is recommended in patients who are receiving intravenous insulin to get glucose caloric source, and the blood glucose values are monitored every 1 to 2 hours, right? And let's look at the different types of monitoring aspects of a severe traumatic head injury patient. So we have the essential monitoring and accesses, and then monitoring and CPP monitoring by measuring MAP. And you also have your brain tissue oxygen tension monitors, and your additional monitoring like EEG and transcranial Dopplers. So in essential monitoring, you have a standard ICU monitoring, which is your NG tubes or orogastric tubes, and you have a CVP line and an arterial line and a urinary catheter. And I just put this picture of the NG tube because recently we had a patient with obvious clinical features are skull-based fractures, and he didn't have a foci of a fracture that was seen on the CT scan. But when I walk into ICU, I've seen them trying to pass an NG tube. So and I was trying to explain to them, like, guys, just don't do this. Do the trick, right? And moving on to ICP monitoring. So as the picture here illustrates, you have different types of ICP monitoring. You have intraparenchymals, epidurals, you have subdurals, you have subarachnoid bolts, and the most gold standard is the intraventricular drain at the level of foramen Monro, because it helps in both diagnostic and therapeutic and therapeutic measures. So it's indicated, ICP monitoring is indicated in all patients with severe traumatic brain injury and abnormal CT, which is a low GCS and abnormal CT. And in patients with two or more of the following features, which is an abnormal severe traumatic brain injury and a normal CT. And if the patients, or if they have unilateral or bilateral motor posturing, or if the systolic blood pressures are less than 90 millimeters mercury. So here we're looking at the various types of ICP waveforms that you encounter when you're looking at ICP monitors. So in blue and A, we have a normal ICP waveform, where you're seeing a P1, P2, P3 waves in a stepped manner, where your ICP, your P1 waveform is considered the percussion wave. It results from the arterial pulsations within the brain. And then your P2 is a tidal wave, and it represents the compliance of the brain. And your P3 is a dichotic wave, which signifies the closure of the. And we'll get back to the abnormal ICP waves shortly. And this graph here is showing the principle of Monroe-Kelly doctrine, and you're looking at relationship between intracranial volume versus ICP and the compliance of the brain. And as you could see, the ICP could vary within a large intracranial volume change up to an extent. But once the ICP reaches beyond a certain threshold, which is usually between 18 to 22, for every minute volume increase within the intracranial compartment, there's an exponential raise in ICP. And as the ICP waveforms are looking like here, as long as within normal limits, which is below 20, you see the separate ICP waveforms. Whereas once the brain loses compliance, you start seeing the increase in the P2 waveform. And these are the Lundberg waveforms, which you usually see in the ICP monitors. And you have, essentially, you're able to identify like three types of Lundberg waveforms. You have Lundberg A, and these usually indicate an abrupt increase in ICP over 50 millimeters mercury, and they usually last about 5 to 10 minutes in increments. And this is usually representation of severely raised ICP and increasing or impending herniation. And these patients, once you see the Lundberg A waves, you need to act on changing your tears in management. And then the Lundberg V waves they have an amplitude of 10 to 20 millimeters mercury, and they have a rhythmic variation of 0.5 to 2 minutes. And then your Lundberg C waves, you don't often see them in clinical practice, and they just follow a normal ICP waveform with some variations every now and then. So this screen is something that we see often, but can one of the juniors go through like what they're seeing here? Like I just want to know if anybody could identify the parameters that we are observing here. There's a patient in ICU. Anybody want to take a try, or you want me to go through it? Right. So this is a yes. Sorry. Go ahead.
Yeah.
Right. So this is a standard cardiac monitor that we see in our patients in ICU or even in theater, right? The one that's attached to on top of the ventilator. And you're seeing your SpO2 waveforms. Well, you're not seeing an entitled CO2 waveform there, but you have your blood pressure monitor, you have your temperature there. And then the one in pink is your ICP waveform. And in this patient, what I had attempted to do, and I was able to get it, is EVD, the regular integral EVD with a collecting chamber, and I used the CVP line and used it and attached to the one of the outlets from the drain and transduced it, and I was able to actually get ICP waveform, right? And this ICP waveform was, I think the value was over 30, right? And you could actually see you lost the down step waveform, and you're actually seeing the P1 followed by a peak in P2, and then there's P3 thereafter, right? So it's quite easy to measure ICP even in our settings where we don't have the fancy integral stuff. And I think medical regions were willing to. They have the ICP monitors, and when I was in South, they were proposing that they will provide us the monitoring if the hospital buy the fiber optics. But I don't think we ever get around it. So, and then you have well, and if you have the monitors that Integra makes, the advantage with that is you could have a continuous reading over a wide range as opposed to limited finite information do through transducing the screen here. So that means you have to keep your eyes on the monitor at all times, right? So anyway, moving on. So monitoring cerebral perfusion pressure, it could be done by the simple formula here. Once you have your ICP, your MAPs, but you measure MAP of the middle cranial fossa by placing the transducer at the level of the tragus, right? And you have to make note that the patient, every time the patient is turned, the transducer is repositioned to maintain at the level of tragus. And the normal CPPs that you aim to have is over 60 millimeters mercury. And then your the last one I'm going to go through in terms of monitoring is your brain tissue oxygen tension. So the normal range you want to manage for it is about 15 to 40 millimeter mercury, and anything less than 15 could predispose a patient to cerebral ischemia. And the principle behind it is you just have a cranial bolt, just like the subdural bolts or subarachnoid bolts, longer probe that goes into the brain parenchyma, and it attaches to the monitor that is dedicated just to read brain tissue oxygen tension. And Integra have a monitor called Lightbox, and currently in UK and Europe and US, they are undergoing trials to see what is the if there is a correlation between brain tissue oxygen tension levels and the outcomes um, in the severe traumatic head injury patients. So, and then moving on, cervical spine, well, we all are pretty familiar with this. You just clear the cervical spine as soon as possible. And as we can clear the thoracolumbar spine within 48 to 72 hours. And then once again, just going to revise everything in summary, and then we'll move to protocols, right? So the initial goals, when a patient gets into ICU, you want them in sedation, with full sedation and analgesia, with paralysis if there's a need for it. And you set yourself targets for PO2, PCO2, and you avoid hyperventilation to bring down PCO2 levels less than 40 kilopascals, except in critical situation when you're just trying to buy time while you're trying to wheel a patient to theater to do a definitive procedure, right? And you operate on primary insults if there are any that need to be that, and they're causing mass effects. And you optimize your cerebral perfusion pressure to 60 millimeters mercury, and your ICP is less than 22, and your brain oxygenation to greater than 20, or 15 to 24, as mentioned earlier. And the temperature targets is normothermia, optimal hemodynamic and volume status, and anti-epileptic prophylaxis for 1 week in severe head injury patients. Establish early enteral feedings within 24 hours if possible. Try to maintain normal glycemic index, and you monitor and treat for infections, and you go on anticoagulation as we discussed earlier. So protocols. Once again, Brain Trauma Foundation had issued or recommended these protocols, but once again, these protocols are not rigid, right? And they always recommend that we tailor these protocols to your needs at your institution. So, and in the Seattle Severe Brain Injury Conference, they actually came up with a list of tier 0 interventions that are viewed as fundamental to the care of patients with severe traumatic brain injury. And that is defined by a GCS of 3 to 8 in a patient with head trauma. And the expected interventions, or what they suggest or recommend, is things that we are talking about all along, which is admission to ICU, intubation, mechanical ventilation to foolproof the lung from any insults, and then serial evangelical status with pupillary reactivity and elevation of the head, analgesia to make sure that patient doesn't have any pain, and but not necessarily directed at ICP. And sedation is to prevent agitation and as a result of ventilator asynchrony, but not directed as ICP. Now, this is tier 0, right? And temperature management is to prevent fever and to measure core temperature and 3D temperature above 38 degrees Celsius. And recommended interventions here are insertion of a central line and end-tidal CO2 monitoring and anti-epileptic drugs for medications for 1 week and initial pressure at greater than 60 millimeters mercury and hemoglobin level greater than 7 and to avoid hyponatremia and to optimize venous return from the head. And arterial line for continuous MAPs and monitoring SpO2 and maintaining at level of greater than 94. And then once you have your basics right, and then you go into you continuously re-examine the patient and repeat a CT scan if there's a need for following the intracranial pathology. And you can and if there's any mass effects that developed at a later point and that could need to be surgically evacuated, you make that call at that point, right? And you consider um, a ventricular drain if the initial ICP monitor is a parenchymal or a subdural bolts. So that way, with the ventricular drain, you could drain CSF and drop the ICP, right? And then you follow your tiers. If tier 0 fails and the patient is not responding, you go on to tier 1. And then you come back and re-examine the patient and you go to tier 2. If they're responding, then you switch back to tier 1 and then go back to tier 0, right? And similarly, when all fails, you go down to tier 3, which is the end of the line, which is the phenobarbital or thiopentine coma with titrated ICP control and burst suppression, or that is only when you would consider a decompressive craniectomy for a patient with no focal surgical target or a space occupying lesion. We'd consider mild hypothermia. And another recommendation that they came up with is this algorithm where in the square where they have the ABCD, they essentially plotted ICP and the brain tissue oxygen tension, and they stratified it based on the value into type A injury or type B injury or C or D injury, right? And this is pretty much the same algorithm that they follows, but it slightly varies based on what class of injury it is. If it is type A, you follow, well, those are normal parameters, right? So you don't have to do anything for them. So if it's type B, you follow the orange tiers. Type C, gray tiers, and type D is the purple tiers, right? And now this is an example for a protocol developed by the Sussex NHS Trust. And I just put it up as an example. Like they essentially break down the whole recommendations by Brain Trauma Foundation and the Seattle conference, and they have the tiers and as described here. So same thing, they have tier 1, tier 2, tier 3, and if tier 1 fails, you move to tier 2 if targets are not met within 60 minutes or hour from starting your tier 1, right? And similarly, within an hour, if tier 2 fails, you move on to tier 3, right? And I'm just showing this as an example of one of the protocols in one of the neuro-intensive units. And this here is of another protocol. And I have to say, I shamelessly screenshot this slide from Prof. Hutchinson, who was doing a talk on his rescue ICP paper. And this was one of the slides, and he talked about how they manage the patients in Cambridge. And they have this stage 1, which is using propofol and fentanyl and head positioning and target PCO2s and SpO2s and PO2s and temperature targets. And if that fails, consider a ventricular drain. If that fails, go into stage 3 with inotropes and PCO2, change in PCO2 targets and temperature targets. And stage 4 is hypothermia, and stage 5 is thiopentine and decompressive craniectomy. And if you notice here, they have a slight variation to the 3 tiers of brain trauma, but the principle is the same. Like they all follow the same tiers of management with slight variation that suits the institutional needs, right? So I think that concludes the my talk on neuro-intensive care. And in conclusion, I'd like to say that I think we have enough personnel now who have come back from UK or who are in UK and those who are progressing in DM. And we could start considering developing protocols for traumatic brain injury in our institutions because none of our institutions have, I'm not sure about Moto, but I know for a fact in Sando and Port of Spain, we don't have a protocol for head injury patients. And currently how it goes is you have patient and casualty. IC comes to review them because they have a low GCS. And first question they ask is what neurosurgery doing for them? And if there's no, if neurosurgery, if we come and say, well, patient need to IC, but we're not operating, then they'll be like, well, we're going to track and send them to the ward. That's the usual response. But that's also because we have like shortage in beds and a whole lot of resources that we are not gifted with. So yeah, but I think at least if we start the dialogue with the ICU teams and start developing protocol, maybe in near future we could have a protocol of our own, and it goes without saying that if you have a patient with severe traumatic brain injury and you're not trying to come up or reinventing the wheel, you just follow the protocol. And once it, because our settings are pretty much the same across the board, we could have the same protocol across all three major institutions that provide the neurosurgical care. Any questions?